All right. Hello, everyone, and welcome to Provincial Stroke Rounds. My name is Barb Kabilis, and I'm the Regional Stroke Education Coordinator with the Central South Stroke Network based at the Hamilton General Hospital, Hamilton Health Sciences. Today's presentation is called Advanced Care Planning in Stroke, and we have three presenters today, Dr. Kelvin, Gillian Maguire, and Leigh Barr. The handout for today's event was circulated yesterday and will be sent in a follow-up email and also be posted on the Central South Regional Stroke website. This website will be archived and can be accessed through the link provided in the follow-up email that you will receive. You've been muted upon entrance to this webinar, but you'll be able to unmute during the Q&A portion if you let me know you have a question, and you can ask that way. Otherwise, you can use the Q&A feature and type in your question. Please remember that the views expressed today are those of the presenters and not the platform being used, in this case, Zoom. We'll have an interactive component during the last part of the session for 10 to 15 minutes, but we'll have a question and answer period. And we hope to hear from as many sites as possible. And again, you can type your questions in. If you wouldn't mind showing Dr. Ung the evaluation slide, unless it's at the very end, I just want to remind you to complete the evaluation. And to do it, you can complete it online with the SurveyMonkey link, or you can use the QR code, and as well a paper copy was attached to the invitation. Certificates of attendance were also attached in the email invitation. Please fill in your name and keep it for future reference. And you can go back to the beginning now, and we'll show our mitigating potential bias slide. And I'd like to introduce the speakers now. This morning, we have Dr. Kelvin. He was granted his medical degree in 2002 at Guy's King's and St. Thomas School of Medicine at the University of London in the United Kingdom. He's trained in stroke medicine at both McMaster University and at Nottingham University, United Kingdom. He's an associate professor in medicine neurology at McMaster University and is the director of the stroke research program at Hamilton Health Sciences. He's the clinical lead for the Palliative Care education program and an advocate for the serious illness care program at Hamilton Health Sciences. We also are fortunate to have Gillian Maguire, who's a nurse, NP on our integrated stroke unit here at the Hamilton General Hospital. Gillian earned her undergraduate and master's nursing degrees at Ryerson University, and she's been a nurse practitioner since 2009. She began her career at the emergency department in Toronto and Milton, and she moved into stroke care in 2018. Her clinical experience has led her to have a passion in end-of-life care and patient advocacy. She is a clinical lead for the Palliative Care education program and an advocate for the continued advancement of the serious illness care program at Hamilton Health Sciences. And last but not least, we have Leigh Barr, a speech-language pathologist with the Integrated Stroke Program. She's been with the stroke program since 2005. She obtained her Master of Science in SLP at the State University of New York at Fredonia in 2004. Leigh is an adjunct clinical professor with McMaster University School of Speech-Language Pathology. Over the years, Leigh has participated in education endeavors with medical education, research and tutoring. Special interests are in the area of aphasia, outcome measures, and palliation and end-of-life care. And now I hand it over to Dr. Ung and our other presenters. Thank you.
Thanks, Barb. Thank you very much for the opportunity to present Provincial Stroke Rounds on behalf of Gillian and Leigh, my two other speakers. This is a bit different from our usual format. We thought we'd present this together to represent the multidisciplinary component of advanced care planning, palliative care, and MAID. And I thought this would emphasize the responsibility we all share in this critical part of stroke care. I want this to be interactive, and rather than having too many factual slides in this, my intention is to really set the tone and frame our discussions later on at the end of this talk. Without further ado, I will move on. So these are the stated objectives of our talk today. Stroke as a serious illness, because it is, and I'm sure I don't need to elaborate on that to this group. We'll discuss stroke and the critical treatment decisions, advanced care planning in stroke particularly, and then Gillian and Leigh will talk about palliative care specifically within stroke patients. And Gillian will give us an update on medical assistance in dying. Stroke is a serious illness, one that we are all very aware of. It is not a niche condition. This is a condition that is very common, especially here in Canada and in Ontario, no doubt. Stating the obvious, stroke prevalence is on the rise. We are doing better with managing our stroke patients, particularly the most severely affected of our stroke patients, thanks to the advent of recent paradigm shifts in therapeutics in hyperacute stroke, particularly with mechanical thrombectomy, CT perfusion tissue windows, making effective treatments available to more and more of our patients. There are more and more stroke survivors, and hence the rise in stroke prevalence. Stroke incidence itself has continued its downward trend because of the success of our primary prevention measures, particularly with our management of hypertension over the past few decades. Despite all the progress we've made, it is still the #1 cause of disability in Canada. And but unfortunately, it is also the result of significant chronic disability. 50% of our stroke survivors remain chronically disabled despite all the treatments we have available. A lot of this disability, a significant amount of this disability is unseen. A study by Clark et al. In a publication in Stroke in 2002 highlighted the fact that stroke doesn't just affect visible impairments such as the ability to move our arms and legs, and the term a recovered stroke often refers to fairly obvious, blunt descriptions of patients who are walking, unable to and are able to return home. Strokes have a persistent multidimensional impairment of health. When you use recall measures or ERDS measures on patients that assess the invisible effects of stroke, such as anxiety, depression, participation across the spectrum. Some of these unseen outcomes that affect our stroke patients are affected by modifiable and non-modifiable factors. Modifiable factors are the amount of resources we provide to them when they recover, but the non-modifiable ones are things such as finances, informal community supports, family members that can contribute to their recovery. Stroke is not just a disease that impacts our patients directly. It has an impact on the patient's family, on their social circles, on the community as a whole. Because it is so common, it has an impact on our healthcare system directly, as it's given the significant burden of morbidity it has on healthcare. It is a very costly disease. The financial impact of stroke is not just on our system, it is also on our patients. I thought these were transcripts from patients who've had strokes. They make very uneasy reading, in part because they strike true as we read through it. This first transcript highlights the fact that strokes have a direct impact on how we see on how our patients see themselves. It changes who they are. And this is something that most of us are very familiar with when we see them in follow-up clinic, how they've been affected by their own personality and how they see their role within their family. The impact of stroke is also felt in how patients feel that people around them see them. Aphasia is a very common example of this. When speech and language is affected, patients feel that people treat them very differently, that they've become less of a person sometimes, that their language difficulties reflect the fact they are not the same person that they used to be. This third transcript highlights the fact that it is still pretty much a taboo topic to talk about some of these invisible impacts of stroke, the fatigue, the energy levels that our patients feel. They feel that this is not something that they discuss openly. It is something that you take it on the chin, that you internalize it, but it is hard. Strokes affect our choices, our patients' choices. Personal finances was one of the things. but it removes a lot, it limits what our patients can do, and their participation with life in general is diminished, even if they are, as I said before, deemed recovered. This highlights how much our patients feel that they become dependent on others around them. That because of the stroke, they now become no longer independent individuals, but dependent on others to make concessions and to help them, and rely on others to make sacrifices to help take care of them. I think most of us are very clear about the fact that strokes are serious illnesses, and they have a profound impact and persistent impact on our lives, even in those that we have deemed to have recovered from a stroke. It is by and large a condition that does not impact mortality as much as it affects morbidity. Given the impact of stroke on our patients, it is important that we try our best to align what we can do for our patients with the resources we have available. In a centrally provided healthcare system, we have to make choices to try to maximize resources for the health and outcomes of the wider community. When we talk about stroke and resources we have available, we need to talk about how to provide it so that it is cost effective, and so that we can improve outcomes for the systems that we and the patients, populations that we take care of. To do that, we need to ensure that we have concordant care. It is not just a systems-wide approach. We need to try to align that with what we want to achieve, and more importantly, put our patients at the center of it so that we talk about what's important to them and we focus our interventions on them. It is easy for most of us, most of the time, to assume that death is the worst outcome, but this is not always the case for all our patients. And ignoring that fact, we do at our detriment of trying to help the person in front of us. Ultimately, it's as much as we want to talk about how we make decisions in stroke care, it's as much as we want to do things right as stroke systems, we need to do the right thing. And doing the right thing involving our patients at the center of a discussion, exploring the options that we have available, and then helping them choose the right option to give them what is important to them. All these are important to improve satisfaction, patient expectations, and all these health-related quality of life. A paper here that highlighted the importance of advanced care planning in the BMJ about 10 years ago highlights how important this is. I want to highlight the fact that one of the key things we need to discriminate between is advanced care planning and advanced directives. Most of our hospital systems have a systems-wide approach that requires us to complete advanced directives in all patients on entry with a critical illness such as a stroke. We have that here in Hamilton Health Sciences. I suspect most hospital systems have that. By itself, it is not sufficient to consider that advanced care planning. We have these discussions often in the moment when patients are unwell, right? Just as they've come into hospital with a stroke, without all the investigations and all the assessments and all the information available to it. There is actually a lot of work looking at the impact of these advanced directives that are done when patients come in hospital. While they are an important part of care by themselves, without a detailed discussion of advanced care planning in a more comprehensive way, they don't actually equate to better outcomes or better patient satisfaction, as they are very superficial. A true exploration of advanced care planning needs to be a bit more in-depth and needs to scratch beyond the surface. It is worth implementing this. As we look at this study, this randomized controlled trial showed that it didn't just help the patients in preparing them to make important decisions. It also helped families make important decisions. It helped reduce stress, anxiety, and depression for the people around them. How do we do these advanced care planning discussions beyond the advanced directives that we do when people come in for A&D offer, A&D decisions and post decisions. It needs to be system-wide. It needs to be something that everyone can do. It needs to be structured in a way so that it can support discussions with patients. It's not an ad hoc discussion when we have, and it's not. We have to be careful. We don't take shortcuts making assumptions. We need common pitfalls are the fact that when we have these discussions with our patients, we use because they are framed around medical decisions. We tend to use medical lingo, which patients may not fully understand as much as we do. And we need to elicit patients' goals and priorities as we describe these treatment options, and we need to make a shared decision making, involve shared decision making throughout all this. So how do we do advanced care planning in stroke? I would start by going into our best practice recommendations. There is a clear gap. We've made significant advances in palliative care across the spectrum of diseases, but no less in stroke. It is firmly entrenched in our Canadian stroke best practice recommendations, but if it is similar in your hospital as it is in ours, there remains a significant gap in standardized advanced care planning discussions. Most of the discussions often stop at just the advanced directives when patients come in, and I've already highlighted that that's insufficient for most of our patients. It needs to be a very structured systems-wide discussion, patients' personal values and wishes. They need to be at the front and center of our discussions. It needs to be documented, and this is not always documented clearly in our hospital system, and it needs to be reassessed daily. Relevant people need to be brought in. It's not always just with the patients, but with the substitute decision maker. The BMJ paper highlighted how the significant impact this has on the people around our patients. I want to emphasize this bit as well, that it is an interdisciplinary team responsibility. There are multiple points in the patient's care with a stroke that we can have these discussions with them. And it's not just with the physicians, it is a discussion, speech and language, as Leigh will talk about, Gillian will talk about, as NPs and nurses. In order to ensure that we practice what we preach in our stroke best practice recommendations, we need to, all stroke patients should be offered a discussion about advanced care planning. These discussions can be directive or by proxy, and ultimately we need to think of our patients and the people around them. Now, there's several ways of providing a systems-wide solution to standardized care. It's not about doing the right thing part of the time for some of our patients. It's about doing the right thing all the time for all of our patients. Here at Hamilton Health Sciences, we've used the Leigh Labs Serious Illness Conversation Guide. This was conceived by the Leigh Labs back in 2012. So it's nearly 10 years in its implementation. The Leigh Labs is a non-profit organization, part of the Brigham Women's Hospital and the Harvard School of Public Health. A very structured approach and very well studied approach to discussions about advanced care planning and serious illness. There's no pressure on the outcomes themselves, but it starts the ball rolling with our patients. There is a component of prognosis, but predominantly focused around exploring patient wishes and goals. A lot of evidence, because it is a not-for-profit organization, and a lot of research and published QI studies out there that talk about how it enhances goal-concordant care, improves quality of life, improves patient satisfaction, as expected with some of the work done by the group that published the BMJ paper. It helps the patients, improves outcome for the patients. It improves utilization of hospice care, reduction in inappropriate hospitalizations, and ultimately improves patient outcomes. Now, these are all not things that were achieved when we used just a simple advanced directive about A&D or not. The Serious Illness Conversation Guide looks a little bit like this. As I mentioned, it doesn't have the prognosis bit, only forms a very small component of it. A large part of it is about listening to our patients and highlighting their goals, fears, sources of strengths, critical abilities, and trade-offs, as well as involving their family in these discussions. It highlighted an important component of the Canadian best practice recommendations, documenting our conversations, and also ensuring that we communicate with key clinicians and that it is a process and it's not just a one-off and we stop. So I'm happy to take questions later on, but Gillian, Leigh, I think you were going to cover this topic.
Correct. Thanks, Dr. Just thanks to everyone for joining us this morning on this. It is a heavy topic, of course, one that's important to us all and of course, necessary to review. Dr. Can I have my next slide, please? So at Hamilton Health Sciences, we're talking about palliative care today. And here we want to recognize that palliative care should not be confused with end-of-life care, which of course is a part of palliative care. When a person on the stroke unit becomes a patient on palliative care or on a palliative care path, the focus then shifts to one of comfort. And with this, we're including medical treatments which may ease the discomfort that a person's experiencing. This ties into the goal or the aim to prevent and relieve suffering. That's what the focus becomes. And included are the patient's families, caregivers, and other identified important people. We recognize that palliative care services and approaches need to be reserved for those whose death is imminent, thinking of the palliative care part of this on our acute stroke unit. Next slide, please. So the goals of palliative care, Canadian best practice guidelines suggest that you have, or that programs have an objective to have a consensus on the direction a person may wish or have previously stated they would wish should they find themselves in such a state. And in our situation, as Dr. Ung was talking about the advanced care and the serious illness conversations, this is where we find ourselves when someone's had a serious stroke and it may be a life-ending event. So when stroke becomes a life-ending event, important to think of what is that individual's wishes. Once this direction is understood, as Dr. Ung was mentioning, it's important that it's written down in a medical record. Further, it's important that it be reviewed, cue shift to recognize that there may be some changes and if there's other discussions that must be revisited. Next slide, please. So we understand, we're all here together with the same understanding that palliative care is something that it's a recommendation that should be on a stroke unit. In our team, what we recognize that while palliative care services were provided and were provided very well, we did not have a formalized palliative care pathway. Next slide, please. And so what we did was we used our hospital, which is Hamilton Health Sciences. Hamilton Health Sciences is a continuous quality improvement hospital. It uses a Sigma 6 framework. And what you see in front of you is a very blurry form that we use when we're endeavoring on a continuous quality improvement project. And that's what we decided to do for the development of a palliative care pathway within our stroke program. Next slide. Thank you. So that's just reviewing the same, correct. So we identified what our problem statement was, and we recognized that our acute stroke unit did not have a palliative care pathway, which was clearly delineated. Next slide, please. And so what we opted to do was make this a continuous quality initiative by partnering with McMaster University. What you'll see on this slide, of course, are the 4 graduate SLP students who took on this initiative with us and raised the bar for what it was that we were trying to do. Next slide, please. And with that came the utilization of a framework called ADAPT-E. And what this framework does is it locates the existing stroke guidelines, and that's what the graduate clinicians did. It then looks to see, can we adapt the palliative care recommendations to our local context here in Hamilton? And then the third part that the McMaster students did was they presented these to the stakeholders at the Hamilton Health Sciences Integrated Stroke Program. And from there, we moved on to our next phase. Next slide, please. Part of the ADAPT framework requires the determining of what the health questions are, a search of what's available out there, and then it narrows it down to how many pathways there are. Next slide, please. What we found was that there were many palliative care pathways. Eventually, the group were able to narrow them down and presented 5 of them to us, the 5 that you see on this slide. Further, the guidelines were reviewed using the ADAPT-E guidelines, which in particular looked at the quality, currency, content, and consistency of each guideline. Next slide, please. And that's what brought us to receiving this information from the researchers, where they looked at the top 3 guidelines that met the criteria that was established. So there were themes that were identified that led to these being the top 3 ranked guidelines. So some of the highlights of the themes were the palliative care process and team training that was established within the guideline, the use of palliative care specialists, a team discussion, further communication, advanced care planning, end of life treatment decisions, counseling. And then when you look at these 3 ranked guidelines, you'll see that they were from the United Kingdom, Canada, and Australia. The Australian ones happen to have the highest ranking for match criteria and overall quality. Now, the 3 guidelines did rank very similarly. We opted at our program to select the Canadian guidelines, and this was led by the medical team in the review of what was presented. And the Canadian guidelines were selected due to the overall quality of the research that was relating to each subsection within the presented information. So that's an important factor to consider here. Although the Australian palliative care guidelines ranked the highest in quality for the ADAPT-E framework, it was the quality of the research and that led us to select the Canadian guidelines. Next slide, please. So here, when we look at this slide, we recognize, of course, the importance of the Canadian best practice guidelines, especially as they relate to palliative care. Our team provides an ongoing review and regular assessments of a person who's along their path of palliative care on our unit. They utilize formalized palliative care processes with experienced teams and looking at the nurses and all of the other allied health staff, the doctors, the nurse practitioner. We provide support and counseling. The social workers on our program are very skilled at being able to have these conversations and provide the support that may be required as families have to engage in the next steps after a person has passed away. So we're very fortunate at Hamilton Health Sciences to have a large interdisciplinary team. I alluded how that's made up of MDs, nurse practitioner, a large allied health team. We also have a palliative care program, and they lend their expertise. Additionally, we have spiritual care who are able to provide further comfort in addition to the social workers who support the family. So on our unit, we have a process whereby we have a means of staff awareness to be able to recognize when a person is palliative within our unit. And we do this by other programs, I'm sure, have similar ways to identify a person who is along such a pathway. In our program, we utilize a picture that's hung outside the door. It's an ambiguous picture, but it allows people on the ward, the staff, to have awareness that this is a person whose life may be coming to an end and that there's additional support to be provided and a bit of an awareness to your language and perhaps even your volume as you move along. I'm going to pass it over to Gillian now. Thank you.
Hi, good morning. So the next topic that we're going to speak about is the medical assistance in dying and the context of stroke. So the highlights to dealing with stroke patients is that often the stroke itself is not the life-ending event. What we're really talking about is loss of independence. It's also about disability and people's values and beliefs around what that means to them. And so also really important to realize that medical assisted dying, or MAID, is not palliative care. It is a medical intervention that is available to patients under certain circumstances, much like a lot of the things that we deal with in the stroke program. So much like offering an EVT procedure or a TPA to a patient, They need to qualify under certain circumstances, and MAID is much the same. And next slide, please. So this is just a outline of where we started and where we have ended up so far in the MAID journey in Canada. So in 2015, MAID became legal after a Supreme Court ruling. Then followed rapid discussions and legalization, and that's where Bill C-14 was developed in June of 2016, where they actually legalized the medically assisted death. Just this past year in March, we had amendments to that bill, and we had Bill C-7, which really looked at the very specific elements of MAID and tried to make it more accessible, and also opened it up to many different patients that wouldn't have qualified before. Next slide, please. So this is, again, sorry for the very small print, but this is a bit of a summary of the MAID process. So as it kind of comes out of a lot of that serious illness discussion that we're trying to have with our patients, really the important part of being a practitioner in a MAID type patient process is that you really do need to examine your own values and beliefs to try to eliminate some of the biases that will enter into this process. So very much like so really, there's two pathways that a person can follow now. There's now a process for a patient that is believed to have a reasonably foreseeable death, as well as a patient that may not have a reasonably foreseeable death. And that really plays into the neurology and stroke context in that, like I said, we're really talking about patients' values and beliefs around their life and dependence and really what they value. Next slide. And so the conscientious objection is allowed for within this legislation. So a practitioner can state that they don't want to be a part of the actual process in MAID, but they do have legal obligations. And so what that means is that if a patient is asking about MAID or is requesting a MAID assessment, practitioners have to provide a meaningful referral. So what that means is that you have to refer to another practitioner or team that will then help the patient on their journey through MAID. We're very lucky at HHS to have what we call the address team. This is the Assisted Dying Resource and Assessment Service. And it is comprised of physicians and nurse practitioners who are the providers, as well as a multidisciplinary support team that adds to the fulsome nature of this service. And so we include nurses, social workers, SLPs, and spiritual care providers. Next slide. So these are, I've in relation to keeping this kind of very specific to stroke, I've picked out some of the things that we thought were important when we're dealing with stroke patients. So again, like I said, the new population is patients without a reasonably foreseeable death. And it also, this next point is very important for stroke patients. As we know, their capacity changes over time by the nature of their illness, as well as where they are in their end of life pathway. And so this final consent waiver, what that means is that the patient can be found eligible after their 2 assessments and can enter into an agreement with their MAID provider that even on the day of the actual MAID provision, if they're not able or capable of giving consent in that moment of provision, they've already given consent for the provision to proceed. This is done in a very specific and purposeful manner. And so the important part is that the patient can change their mind at any moment of this process. And so the things that are described at the provision stage, if the patient was not capable, you have to be very specific about going over what would be seen as a change of a mind, that they are revoking their consent, as opposed to involuntary movements or reactions that might happen. Again, considerations that are important. This cannot be done by a substitute decision maker or a power of attorney. MAID cannot at this point be part of your advanced directives. And so the patient really needs to be able to consent themselves and needs to ask for it directly. But what this really means is that you need, as practitioners, we need to make sure that patients are aware of all of the services and procedures that might be available to them. And that's where this serious illness conversation comes into this process. Again, not all patients would be looking for this procedure, but if a person doesn't know it's available, they can't give real informed consent about their wishes at the end of life. Resources are available on the HHS website. And of course, you can always reach out to one of us and we can provide extra resources. Next slide. So in terms of the death not foreseeable, when we look at stroke patients, it is sometimes difficult to prognosticate about their end of life journey. Stroke in itself, once you get out of the hyperacute stage, may not be the limiting factor for a patient. We're often, again, looking at fragility. We're looking at the ability to take in enough nutrition and things that are a little bit different than some of the traditional, when people think about MAID, the diagnoses that may have made a patient go in that direction. And so some of the things that are really important are that a practitioner with expertise in the condition the patient has that they're asking for MAID needs to be consulted. And the really important part about this is that a patient needs to be informed about all of the things available to them to relieve their suffering. And so when you enter into a MAID assessment, certainly if a patient, it's different to say that the options available are not acceptable to the patient, as opposed to not knowing what is an option. And so again, patient advocacy is very important at this point. It's not about what the doctor or the nurse practitioner or any of the other providers in the patient's life. It's really about what the patient sees as acceptable. And so again, having informed consent in a way that the patient knows what happens when they accept a treatment, but also in a very non-judgmental way, what will happen if they don't accept the treatment. And so again, those discussions as part of the serious illness conversation are very important. Next slide. So in terms of the waiver of final consent, for this particular form, the patient does need to have a reasonably foreseeable death, and the practitioner has to inform them that they may be at risk of losing their capacity. And again, just letting the patient know a lot of kind of what to expect at the end of life as things change, as they you never want a patient to tell you that they're not accepting pain medication or symptom management solely for the purpose of being awake and being able to control their decisions. You want to make sure, that's why at the end of life that having ongoing conversations with the patient about what they think is important, what they value, again, should be a part of this process. So it's always I always inform patients and families that we are on the journey with them. They are the captains of this ship. We go where they go. And really, it's our job to, again, keep comfort at the forefront and make sure that they know exactly what is coming. The form is a written agreement between the practitioner and the patient and can be filled out before the day of the actual provision. Again, consent can be withdrawn if the patient shows refusal by words or sounds. But again, those discussions should be very specific at the time of signing the consent. So again, just in review, we hope that we've gone over a stroke as a serious illness, as well as talking about stroke and critical treatment decisions. Often the special considerations with stroke patients is that it's often an in the moment change of life. It's not the same as some of the chronic illnesses in which you see a trajectory coming and you can have advanced discussions about this. Stroke changes your life in a moment. And so it's important for all of us who have contact with patients at multiple levels of their care that we're having these discussions about what they value and really encouraging them to talk to their family members or their decision makers, because we all know we've all been in those hyperacute situations in which we're asking substitute decision makers to make decisions on the behalf of their person in a hyper emotional state. And it's virtually impossible for us to be able to make decisions about the quality of life that our loved one would want without considering our quality of life in that moment as well. And so important to have these discussions on an ongoing basis and to continue to encourage our patients and families to have these discussions amongst themselves. Thank you so much for having us, and we will open the floor to questions.
Thanks, Gillian. Thanks, Leigh. There was a question in our Q&A, and I hope that was answered. Gillian, could you clarify what happens if a patient is not able to say yes on the very day of?
Absolutely. So what happens is that the waiver of final consent is signed generally at the same time that you're signing the general consent for the procedure. At HHS, we've developed a form for the waiver of consent that is very specific about what the patient is able to do in the moments. And so I know that the conversations I have are around the involuntary movement. So if you go in and you touch the patient and they flinch or they groan, when you go to flush the IV line and they may retract the arm because of the pressure of the infusion, that those are not actions that relate to the patient now refusing the MAID procedure. And so really the specific question that I ask in those moments as they're signing the consent is, do you want me to proceed with this procedure, even if you're not able to answer the question on the day? And almost always the patient will say yes. But really that's a discussion between the provider and the patient. And it's, again, very specific on the form, what we'll fill out. But really it's a matter of asking the question of the patient in the moment of doing the consent, that they would still want us to proceed. Even I use very specific terms, like if the patient is unconscious, if the patient is, again, not capable or delirious, and because the patient has to be capable when they sign the consent, you can have those discussions with them. And again, I often have the discussions with family members or others in the patient circle in the room, so that everybody's really on the same page on the day of provision, so that everybody kind of knows what to expect. But generally the question really is, if you're not able to consent on the day, do you still want us to proceed? And that's really what the waiver is.
Thank you, Gillian. Barbara?
We have another question in the chat. Knowing post-stroke depression is common, is there a risk of a patient asking for MAID when actually management of the low mood could change their wishes? Good question.
I can answer that question if you like. Gillian, so I think one of the things I wanted to highlight here is that before we get too drawn into discussions about palliative care and MAID, and those are options that follow on, but they're not exclusive. It doesn't have to follow on after an advanced care planning discussion. I wanted to de-emphasize the outcome of the discussions and focus more on the reasons behind that choice more. The guidelines emphasize advanced care planning discussions. And I think I highlighted in my talk earlier on that advanced directives are not alone for whether we resuscitate someone or not. It's not really, it's too superficial to constitute a true advanced care planning discussion. We have to talk about stroke as a serious illness. We need to explore what's important to our patients, and we need to do that in a systems-wide and multidisciplinary approach. We need to do this because all those assessments, all those discussions documented up, the sum of all of that lead to eventually a decision of a choice by a patient. And those choices doesn't have to be palliative, doesn't have to be made, but could be either of those things. When we come to a decision about made by the patient after considering all the other options, Gillian, I think there are, jump in after this, but there are very clear assessments that are required of the first and secondary assessor. And one of those assessments include the fact, have you considered all other reversible conditions and considered all options that you can offer the patient before you make a definitive decision about medical assistance in death. So you do need to consider all these things. And often in some of these assessments, we may bring in, the assessor may bring in a psychiatrist to assess the patient. But again, it's usually helpful when you have a multidimensional approach across time to make a decision about this. So all those advanced care planning discussions you've had before, they feed into ultimately this decision. It's not so much the decision that matters, it's more the reasons behind the decision.
Yeah, it is really important to the assessments that we do are very fulsome. And certainly as you enter into these assessments with patients, it's very intimate discussions that you're having. And if there's ever, like Dr. Ung said, if there's ever a question of an underlying reversible cause, the questions to the patient really are, is the treatment for that acceptable to you? The assessment includes a lot about the patient before stroke. What did they value? What did they do in life? What is really leading to the decision of made? I certainly, we never hesitate to have other practitioners come in and consult for us. This is a very open discussion with a patient. And certainly if I'm ever questioning if there's a mood component to this, I ask the patient, is this coming from, are you depressed about these? Is this a depression, or is this a kind of a change from your baseline at all? And certainly you get a lot of clues about talking with the patient about what they valued before the stroke. Often, like Dr. Ugg said again, you also are doing this. There's two independent assessments that happen. And so again, there's lots of consultation that happens with the patient. Sometimes these assessments can take over an hour as you're having discussions with patients. And really it shouldn't be a one-off. It shouldn't just be kind of a physician or a nurse practitioner or kind of flying in to ask these questions and then flying out to do it should be an ongoing discussion with the patient, with their primary team, with other, we certainly lean on our social workers and our spiritual care providers to provide this kind of mood and emotional support for patients. And also knowing that there's a difference between a low mood in context of a change and a real depression that needs medical intervention. And so patients actually are often able to very clearly articulate the difference between these two things. Often patients will say point blank, I'm not depressed, I'm just done. And you have to start to kind of get comfortable with some of those discussion points with patients for sure. And that's why it's also important whenever possible to include friends and family of the patient to give you context of who that person was.
We have a number of questions in the Q&A and in the chat. The next one is, can you outline the role of the SLP in the MAID process at your site? And is there a dedicated SLP to the MAID program, or is the team consulted as needed only?
That one sounds like you, Leigh.
Okay, I can take that one away. Good question. There is a SLP with the MAID program, and that's in a way ironic because the SLP is a coordinator for the program. So that person is able to provide their skill with being an SLP as it relates to MAID. Now on the unit, if an individual requesting MAID also requires communicative support, there are speech language pathologists readily available, and if they're not conscientious objectors, they are able to participate in supporting the conversation for a patient. I hope that answered your question. There's also a question there, Barb, from Dr. Ochkovsky.
Go ahead, Leigh.
The question from Dr. Ochkovsky, I don't think I'm the person to answer it.
Okay. How can we disconnect palliative care from dying and treat it as an active process?
So that's really about having ongoing discussions with family. That's where the serious illness conversations really come in. So palliative care is a very active medical decision and process. And what the overarching goal is that we shift to patient comfort and symptom management as opposed to diagnostics and curative treatments. And so patients can enter into a palliative care plan where really there's no active process that's going to end their life. What they've decided is that they don't want any more invasive treatments. This can be from advanced planning with families. So sometimes some of our patients will have wishes around if they're have large cognitive impairments, dementias, things of that nature, in which really sometimes what I'll say to the families as we're making these decisions is that we're just going to let the patient be the patient. We're going to respond to what they need, and that we're not going to look for causes for what's going on, but really we're just going to support the patient where they're at. And really it's about having those serious illness conversations over the continuum of care, that we really want to keep the patient's values and goals as the beacon that we're following. And that some patients, again, I'm a bit of a Jurassic Park geek. And in the first Jurassic Park, one of the characters said, just because we can doesn't mean we should. And so really making sure that the patients and families together, that the treatments that we are proposing are acceptable to their values and beliefs. I think as humans, we're a little bit uncomfortable about talking about our death and our immortality. And really it's about making patients comfortable to tell us what they want, that it's not coming kind of from that top down, that the medical practitioners are telling patients what they need. Mm-hmm. It's about hearing what the patient needs, and making sure that their medical plan fits that.
Thanks, Gillian. There is a very good question here from Tara. I'll just read that question. Given the sudden onset of stroke and the traumatic like context the patient finds themselves in, how is the patient expected to make a truly informed decision about important decisions like medical assistance in death when the prognosis may be positive, but the current function is low? So this is a very good stroke relevant question. This is one of the challenges when with the advanced directive that is required for most stroke patients when they come in right in the emergency department as it stands right now. Now, as much as we do need to try to have the important discussions, the difficult discussions with our patients when they've had strokes, and we need to get some guidance because strokes don't declare themselves. People have strokes. Most patients don't know the day they have their strokes. And also conversely, most people don't know the day they're going to die. It's important to have these difficult discussions. Now, the advanced directive discussion about A&D post, they actually don't explore, they only scratch the surface, as I mentioned before. When you talk about a sudden acute stroke, there's a limit to how much discussion you can have, especially about goals of care down to palliation or even medical assistance in death. In response to your question, if the patient does not have capacity, too early, not enough information, not taking on information, they're aphasic, they're in a state of, they are not in a psychological state that they can make good decisions, they're not holding the information, the patient may be deemed not in a position yet to make a clear decision. You can refer the patient for MAID, but part of those assessments include deciding whether the patient has the capacity, the ability to make this decision. It is not just a patient decision. Where possible, we try to involve the families as much as possible. There is not an exploration of just the here and now of the sudden event. There needs to be an exploration of what the patient's wishes were like before and whether everything is consistent. It cannot be a single dimensional decision. It's a decision that takes into account time, context, and also the people around the patient. Tara, I hope that long-winded answer answers your question to some extent.
It's good to also keep in mind that the concept of a good outcome is a personal definition. Outcomes are very variable in stroke patients. And so really exploring what that means to the patient. Every person has a different value system and what they would deem to be a good outcome. And it's also important we talk about this in the context of MAID, that MAID is not an emergency. It's not part of hyperacute care in any way. The process of assessing for MAID and talking with the patients is not something that we do again, in that hyperacute state. Really, we take the time to do a lot of our stroke workup so that we can better prognosticate and really make sure that a patient is getting informed consent for the MAID process, that again, that they know it's available, but also that other things are available to them as well, whether that be a palliative care pathway or other, if they decide to take on more aggressive, active medical treatments. Again, it's that ongoing discussions with patients and families, but really important to keep in mind that MAID isn't part of the hyperacute stroke process. Really, it's about as we get to know patients over a few days, and then really getting to know from the patient and the family what they value.
Leigh, there's going to be a question for Alda T, but if you don't mind, I'll answer Dr. Shkowski's question first, then I'll pass the last question to you in the Q&A. So Dr. Shkowski asks, being able to accurately prognosis is important. Patients with cancer get worse and stroke improves. That's the challenge. I actually want to emphasize a few things about the serious illness conversation. Prognosis only forms a small part of the discussion. The key component of the serious illness conversation is actually an exploration of what is important to the patient, and for the family to understand what's important to the patient. Now, the serious illness conversation is very clear, as do the guidelines, that it is not a moment in time decision. The serious illness conversation doesn't even have to have a decision. It's the act of having that conversation, documenting it so the values are clearly formed. Over time, they evolve, and you update those thoughts and decisions by the patient. And it's important that, as you mentioned here, as stroke improves, this constant reassessment is important because it shapes the choices that the patient has, the trade-offs that they have of what they have available and what they do not have. Prognosis is a part of it, but it's not the only bit. It's understanding the reasons behind why a person feels that way and what's important for it, and less about the outcome and decision they have. Those things are secondary after you've explored the background behind it. Whereas I hope that answers your question to some extent, and I'll pass it on to Leigh.
Thank you. And I think mine to answer Sandra Anderchuk's question. And I actually don't think, Sandra, that I'm the correct person here. So let me see if I can. As for the question is, are there resources for patients in outpatient clinics that are available to patients to inform them of importance of advanced care planning, such as general internal medicine clinic or cardiovascular clinic? Now, on our acute stroke unit and on our rehab stroke unit, yes, those resources are available. As for the outpatient clinics, Barb, I wonder if you could tell me if there's any of that in the neuroambulatory clinic.
That's a great question, Sandra and Leigh. I would say no, we don't display it, so we don't ask people to think about it when they come into the clinic, but we are, and this would also include the stroke prevention clinic, but we do have the resources available to answer those questions, and we would help patients on that pathway if that was important and possible and appropriate. But I don't know that we advertise it. Well, I know we don't.
We are lucky here at HHS. We're actually at the beginning stages of a corporate initiative to really look at all of our palliative care practices and the serious illness conversation guide. So the acute stroke unit has been very fortunate to be chosen as a model cell for this program. And so we're going to be the first unit that goes through it, where in a very purposeful fashion, all of our healthcare professionals are going to go through some very specific palliative care education as well as the serious illness conversation, and really looking at doing this in a corporate way so that patients that are coming into the hospital for any reason will have these types of resources available. We are very much at the beginning of that process.
We're at time, everyone, and I have the wonderful problem of having such a great discussion and so many questions in the chat and the Q&A that we weren't able to answer today. So thank you for that great discussion, and thank you to our speakers. I did want to let you know that our next provincial stroke rounds will be held on December 1st, 2021 by the Northwestern Ontario Stroke Network. And the topic is risky behaviors after stroke. How can we support? And the speakers are Michelle Allen, bioethicist, Martina Nuttall, clinical nurse specialist in mental health services, and Christina Johnson, nurse practitioner. And again, I'd like to thank our excellent speakers today. So wonderful to have the panel. Thank you, Leigh Barr, Gillian Maguire, and Dr. Kelvin. I thought it was a great discussion today and a great presentation. Thank you very much.
Thank you.